Hey, BC here for BC Nephro. I'm Dr. Brian Cronin, nephrologist and clinical specialist in hypertension. Today's topic, interstitial nephritis. For more information, check out the videos at this channel and the articles at bcnephro.com. The link will be in the description below. Now let's get into it. Interstitial nephritis is an important cause of acute kidney injury. About 13% of biopsies done for acute kidney injury may show this diagnosis. It also can cause severe forms of acute kidney injury with oliguria and dialysis requirement. In addition, it is difficult to diagnose clinically. Some of the findings are not terribly common, and biopsy is often required to make the diagnosis. So interstitial nephritis can be caused by medications, by systemic autoimmune diseases, and by infections. Today we're going to talk about the most common cause, which is medications. My approach to thinking about the diagnosis of interstitial nephritis, when I consider a kidney biopsy, and when I consider treatment with steroids. And at the end, I'll give a special comment on the use of immune checkpoint inhibitors. The classic description is the triad of fever, rash, and eosinophilia. This, however, is relatively uncommon. About less than 1/3 of patients will have each of these individual findings, and only about 10% will have the triad of all three. When this was first described, the most common cause of interstitial nephritis was methicillin. Methicillin is not made anymore, and even though antibiotics can cause interstitial nephritis, some of the more common causes are things like proton pump inhibitors and immunotherapy. Also, they talk about white blood cells on the urinalysis. This may be only present in about 50% of cases, and they talk about urine eosinophils, and a study has shown that this really has poor sensitivity and specificity. There's only sensitivity about 30% and specificity of less than 70% for the diagnosis of biopsy-proven interstitial nephritis. So you need to be an astute clinician and have a high index of suspicion. The first part of this is knowing the medications that can cause interstitial nephritis. These include antibiotics like penicillins and cephalosporins, but you also need to think about things like quinolones, especially Cipro and rifampin. Other antibiotics such as vancomycin and sulfa, trimethoprim sulfa, can cause interstitial nephritis as well. Some of the more common causes, evolving causes, are proton pump inhibitors and immunotherapy, and there are many other medication causes. Check out the article at bcnephro.com for a more comprehensive list. Then you're looking at the timing. Does the timing of this medication make sense with the development of the acute kidney injury? This can be difficult as well, as the timing can be from several days, such as with antibiotics, to weeks to months. The average development of acute kidney injury, interstitial nephritis with checkpoint inhibitors, for example, is 14 weeks, although there's a wide varying of presentations. Then look for the suggestive findings. Although they're not common, if they're present, they may point in that direction. So we're looking for fever, rash, eosinophilia. May only be present in about 20% of patients. We're also looking for abnormalities on the UA. A microscopic hematuria or leukocyturia, white blood cells in the urine, may be present about 50% of the time, and there often is proteinuria. The proteinuria is not severe. It is in the subnephrotic range in most cases, so look for these findings. But the urinalysis can be completely normal. This leads us to situations where we need to make a definitive diagnosis with kidney biopsy. So when am I thinking about kidney biopsy? I'm thinking about kidney biopsy if the acute kidney injury is severe, if the medication cannot be stopped. There are certain situations where the medication is important, such as using a specific antibiotic for a severe life-threatening infection or using a checkpoint inhibitor for an active malignancy, and if there is a differential diagnosis and it's not clear what the cause is. Next, when am I thinking about steroids? So steroids I'm thinking about using in these severe cases of acute kidney injury, and if the medication is stopped but the acute kidney injury doesn't improve or continues to worsen. So the first step would be to stop the medication if possible, and if after several days, up to a week, the kidney function is not improving, then it is reasonable to give a course of steroids. If I'm giving steroids in this case, I'm thinking about doing a kidney biopsy. The steroids is usually relatively brief. It's a 2-week course of about 60 milligrams, 1 milligram per kilogram. I usually use 60 milligrams with a taper over several weeks. Finally, a special case is to the immune checkpoint inhibitors, because these are used for cancer, so you can't just say don't take the medication. So in these cases, where there's a consideration of a checkpoint inhibitor, immunotherapy, interstitial nephritis, I'm liking to do a kidney biopsy. And even if this biopsy proven, we're treating with steroids, but I'm looking for any way to get the patient back on the medication. So here's my approach. The first thing is It turns out that the majority of patients who have interstitial nephritis with checkpoint inhibitors are also on another medication that can cause interstitial nephritis, commonly proton pump inhibitors. So what the theory is they're on a medication that can cause the interstitial nephritis, but the immune system is kept in check and preventing this adverse reaction. And then you add the checkpoint inhibitor, it unmasks the ability of the proton pump inhibitor or the medication to cause the interstitial nephritis. So the next thing I'm doing is I'm getting the patients off this medication. So the second thing to consider is if the medication is effective. If they're on a combination CTLA-4 inhibitor, that's ipilimumab, with a PD-1 or a combination treatment, the interstitial nephritis is more common with the CTLA-4 ipilimumab. So you can see if treatment with the PD-1 inhibitor by itself as monotherapy would be sufficient, adequate treatment. The third thing, which is reasonable to do, I haven't done this yet, but I've read about it, is to use a low-dose steroids when the patient is rechallenged for the first couple of cycles. That's like 10 or 20 milligrams of prednisone. So that's it, approach to interstitial nephritis. If you found this video helpful, please share it with someone else who you think might benefit from the information. Also, hit like and subscribe, and this is the way that helps me get this message across to more people. Thanks for watching. Until next time.